Greetings, Patho students, and welcome to week 8. And we're going to address the gastrointestinal system and the hepatobiliary system. Hepato, liver, biliary refers to gallbladder. So this is basically our whole digestive function from the mouth all the way down to the anus and all of the abdominal organs, which you'll find there are many that are considered part of the GI tract. Some of these organs have multiple functions. They have duties responsible to the immune system, duties responsible to the endocrine system, and also to the gastrointestinal system. So we'll differentiate some of those organs as we hit them. We're looking at chapters 28, which is the overview of the A&P. We're looking at chapters 29, which is disorders of the GI system, and chapter 30, disorders of the hepatobiliary and exocrine pancreas function. So in chapter 28, which is the overview, again, this is individual for you depending on how long it's been since you've had anatomy and physiology. But this is a good chapter, a good overview with lots of great graphics that will remind you about how basically complex the GI system can be. Do refer to figure 28-1 for an overview of the upper and lower GI, the three parts of the digestive tract. This matches their structures and functions. That will get you warmed up. Be reminded that figure 828-2 is a depiction of the upper GI tract. So how do we define the upper GI tract, which is basically the mouth, all the way down the esophagus, the stomach, up to the duodenum, which is the very first section of the small intestine as it leaves the stomach past that pyloric section exit of the stomach. Below that, obviously, the lower GI. Also referred to figure 28-4 related to functions of the peritoneum, the mesentery, and the greater omentum. I want to spend a minute on the word peritoneum. So we talk about the peritoneal cavity. I just want you to be able to differentiate that word from perineum. There's an extra syllable when we're talking about the GI tract or gastrointestinal or abdominal area. Peritoneum, peritoneal cavity, peritonitis we'll talk about. That all refers to this membrane that basically engulfs or surrounds all these GI organs, including the intestines, the liver, the pancreas, the gallbladder, etc. Not to be confused with perineum, which is basically your crotchal area, men and women. And for instance, if you were a bike rider, a cyclist, and you had an accident, well, that's not a good example. I was going to say you might endure a perineal injury if you're in an accident, but you could also endure a peritoneal accident depending on if you went over the handlebars, etc. Just know that those are two different words. They're spelled differently, and they have very different meanings, and they refer to different regions of the body, so that you'll sound like a person who knows what they're talking about. When we hear about patients getting in trouble with adhesions, postoperative adhesions, which is basically scarring formed after any kind of an abdominal procedure, we're talking about these adhesions. They occur usually in the omentum, which is another layer of the peritoneum. So do refer to that figure 28-4 to refresh yourself on their location and function. Related to the GI tract, I want you to read about how the neurological system impacts the GI tract, how the parasympathetic and the sympathetic nervous system innervates, we call it, the GI tract, how that system affects peristalsis, for instance, and bowels in general. So do read about parasympathetic stimulation and parasympathetic stimulation to the GI tract. And then review the term peristalsis and know how basically that moves food or food product through the GI tract. Then you're ready to move on to chapter 29, which is disorders of gastrointestinal function. A couple terms. Again, I want you to be able to differentiate between some sound-alike terms. One is dysphagia, spelled with the P-H-A-G-A, D-Y-S, P-H-A-G-A, dysphagia, which is a difficulty in swallowing, versus dysphagia, which is dysphasia, dysphagia. If you're, well, this is the example I was going to give you, also could work both ways. If you have a stroke, you could have dysphagia, difficulty swallowing, but you could also have dysphagia, difficulty speaking, depending on what part of your brain is injured in the stroke. So dysphagia refers to the ability to communicate properly, where dysphagia is the ability to swallow. I want you to look at figure 29.1 related to hiatal hernia and the exact location. What is a hiatal hernia and why is that a problem for patients who suffer from it? And then a really big disorder in our country is GERD, G-E-R-D, which is gastroesophageal reflux disease or disorder. Some refer to it, your book refers to it as disease, some others call it disorder. This is a risk factor for coronary artery disease, and it is, I want to say for some reason, it's huge in our country. There are some countries where patients don't suffer from GERD. I guess we call it the American diet or the supersizing that our country is so into. GERD is on the rise, hence a whole aisle full of over-the-counter medications that you can get to help address the symptoms of GERD, as well as some prescription meds. One complication in particular of GERD, which is Barrett's esophagus. Refer to figure 29.2 related to that. Then moving on, gastritis and the mucosal lining of the stomach. Why does the stomach not digest itself? It's full of hydrochloric acid and such. Why does it not digest itself? Why does it not auto-digest? It has to do with the mucosal lining of the stomach, of a healthy stomach. So read about gastritis. What are some of the causes and what can we do for gastritis? And I'll tell you one of the main causes is a bacteria called Helicobacter pylori. We refer to it as H. pylori. H. pylori gastritis. So look at figure 29-3. That is a culprit that has been identified probably in the past couple decades as a primary cause for peptic ulcer formation as well. And you can go on to read a little bit about peptic ulcer formation. Then we're coming to disorders of the colon. Two big ones, and they are often confused. One is irritable bowel syndrome, or IBS. The other is inflammatory bowel disease. You'll see a myriad of causes of irritable bowel syndrome. And in some ways, I guess that's good because many of those causes can be directly addressed. And if you can identify the cause and address it, then basically you can control your symptoms of IBS, or in some cases eliminate it. Versus inflammatory bowel disorder is typically an autoimmune disorder, and it is an umbrella. So under the umbrella of inflammatory bowel disorder are two specific disorders. One is Crohn's disease, one is ulcerative colitis. And sometimes I try to say, I'd rather have this than this. In this case, I would rather have neither of those because they are autoimmune disorders. And when you're dealing with that, you're dealing with, in many cases, having to take ongoing rounds of steroids, and that affects the immune system, that opens you up to infection. I'd like you to refer to table 29-1, which is a table of Crohn's versus ulcerative colitis. Some of the biggest differences, and when a patient first presents, for instance, in an emergency department, sometimes you can't tell which disorder they have, and in some cases it's not that important to be able to differentiate because you have to treat the symptoms that they're having initially. But Crohn's is the one that affects the initial lining of the colon, where ulcerative colitis affects all three layers of the colon. And the other difference, the other major difference, like you might come across tests by the time you get to NCLEX, is very often bloody diarrhea is associated with ulcerative colitis. So if you think of blood and ulcers or bleeding ulcers, that might help you to, as a memory tool, to, if the question has a patient presenting with bloody diarrhea, it's more likely to be ulcerative colitis. Patients present in a hospital setting when they have flare-ups or exacerbations, or something happens where their symptoms get to a point where they require fluids, they require pain relief, in many cases they require antibiotics. I took care of a young physician once in my career when I was working on surgical oncology, who had come into the hospital. He was in his early 30s, and he had ulcerative colitis, and he had been diagnosed for about 12 years. He was telling me that his medication was costing him $3,000 a month, and that his decision was to come into the hospital to have a total colectomy. Basically, his entire large intestine was being removed, and he would then live with an appliance. He was getting a colostomy, and then basically his small intestine was brought to the surface of his abdomen, and he would have an external bag for the rest of his life. And to him, he not only the financial implications of dealing with a disorder like this, but the inability to practice his profession, because he never knew when he woke up in the morning if he was going to get hit with symptoms or not. And when things got bad, he had to leave. He couldn't be looking at 4 patients an hour when he'd had to be in the bathroom having bloody diarrhea, basically, and eventually go to the emergency room for fluid and electrolyte replacement and antibiotics and steroids, etc. So his choice was to basically just eliminate the problem. And I was shocked by his decision, but as I listened to the decision tree that he went through to get there, I was impressed with how courageous he was to take control of things like that. So as I said, I would not choose to have either of these disorders. But you need to read, and then you need to come away with this knowing the difference between irritable bowel and inflammatory bowel disorders. Then I'd also like you to move on to look at the diagnosis and treatment of infectious disorders of the GI tract. In particular, read about rotavirus, and then the chief bacteria that we battle with constantly, especially in the hospital, is Clostridium difficile. Clostridium difficile, we call it C. diff. The difficile came because evidently it was very difficult to culture this spore. And this is one that is very virulent. It holds on. It is a spore, and it lives in many people in their GI tract. And your normal gastric mucosa and then the normal bacteria that you have keeps it in check. But when patients are introduced to rounds of antibiotics, the antibiotics start to alter the normal flora that you have in your GI tract. And in some people who are susceptible, this Clostridium difficile then flourishes, and it becomes a full-on infection, and now we're dealing with that instead of whatever the initial disorder was. It can be deadly because there are so many strains of C. diff now that are resistant to our antibiotics, which is probably one of the scariest things that we currently are dealing with in healthcare, in particular in the world of infection control, is how to deal with Clostridium difficile and hospitalized patients. Then moving on to another interesting disorder, diverticular disease. So we have diverticulosis, which is the inflammation of the diverticulum, and then we have diverticulitis, which is the flare-up. And there's some pictures for you in your ebook, figures 29-8 and 29-9 from the outside. There's a graphic of what it looks like from the outside of the large bowel, and then also from the inside. And that would be a cross-section probably of a portion of bowel that was removed operatively. And that's the final treatment for diverticulitis that does not respond to a more conservative approach. The patient will undergo surgery and have that portion of the bowel cut out. But you'll see that the result is these little outpouchings. And when you see the cross-section, when you look at the actual photo of a cross-section of bowel that's been removed, you'll see why. That all these little outpouchings are like little cavernous little caves, tiny, but food gets caught in them, fecal matter gets caught in them, and then as you know, your GI tract is meant to pass substance through. So when something gets caught and doesn't pass through, it goes on to develop an infection, and it can be very serious. Moving on to motility disorders. Here we're basically talking about diarrhea versus constipation. So read about what the common causes of those motility disorders are, and a little bit about acute and chronic diarrhea. And as a new nurse, I used to think my patients admitted with diarrhea, why aren't we prescribing antidiarrheal medications for this patient? Why does the patient even have to be admitted to the hospital? Well, in many cases, the treatment for diarrhea is to let it run its course until we figure out what the cause is. So in some cases, we don't really want to stop the diarrhea because it is your body trying to get rid of something that needs to be gotten rid of. So if we give you antidiarrheal medication, basically to slow the motility of your GI tract and slow down that diarrhea, we could be prolonging the term of that local infection, basically. So read about the treatment of diarrhea and then constipation. And then moving on to intestinal obstruction or GI obstruction, look at figures 29-10. Remember when I was talking about the peritoneum and peritonitis? Here's where you'll read about peritonitis, which is inflammation of the peritoneum. So if your patient has a diagnosis of peritonitis, that means something underneath the peritoneum, something within that abdominal cavity that is enclosed by the peritoneum has something going on. There's inflammation of something, there's been disruption of something, there's a perforation possibly, and either chemical or bacterial contaminants have been let loose within that peritoneum, and the actual lining becomes inflamed and starts to cause intense pain, which is a good thing because it gets people's attention, and abdominal pain will bring people into the hospital. But it can be very serious because if it's not addressed properly and the underlying cause isn't identified, the patient can develop sepsis. So it's not to be taken lightly. Moving on, read about the diagnosis of malabsorption disorders or malabsorption syndrome. You can read here about celiac disease, which we've heard a lot about probably in the last 10 years. Patients who are literally intolerant of gluten, celiac disease. And then this chapter ends with an overview of colorectal cancers. So here I want you to read about the diagnosis and the prevention. Colorectal cancer, they say, is totally preventable if patients are properly screened according to the recommendations, and that screening involves colonoscopy, which is visualization of the colon, and that should start at age 50. Or if you have a history of a first-degree relative is a parent or sibling who has or had colorectal cancer, then your screening might start earlier than age 50. And then after that, that colonoscopy is recommended every 5 years. Move on to chapter 30, which is disorders of the hepatobiliary and exocrine pancreas. Here we're going to talk about the liver. The liver is an awesome organ. It literally has 400 functions, and I'm not exaggerating, just like, oh yeah, it has 400 functions. It does have 400 functions. Table 30-1 overviews about 20 functions, some of the major functions that you can relate to. So backing up, so I told you table 30-1 is the functions, but backing up to figure 30-1 and 30-2, the first is the anatomy and physiology of the liver, and the second is the portal circulation. Portal, when we hear the word portal, P-O-R-T-O-L, we're talking about circulation of the liver, or hepatocirculation. That refers to the word portal. And that is the blood into, through, and out of the liver. The liver has a unique circulatory system. At any one time, there can be between 1.5 and 2 liters of blood pumping through the liver every minute. So you can imagine it's a high traffic area. So to break it down, there's approximately 300 milliliters of blood that enters the liver through the hepatic artery, and then there's another liter of blood that enters through the portal vein. So it's not just an organ that is being fed to keep itself alive, it's also a clearing station, as blood from the GI tract, blood from the spleen, blood from the pancreas also pass through the liver on their way to the vena cava. So it has its own system of blood circulation for its own function as an organ, but it also is this grand central station. That's why the huge blood supply. The liver itself probably doesn't need 1.5 liters of blood per minute to survive, but its function is to filter all this blood from other abdominal organs. So the venous outflow from the liver carries to the hepatic veins, which empty into the inferior vena cava, which that's at a place that is right about the level of the diaphragm. So at any given time, it's said that the liver stores about 1/2 liter of blood, and this can be called into the circulation when the body senses there's a drop in blood pressure or a need for increase in circulation. And we also know that in cases of right heart failure, when the pressure of the vena cava increases, the blood flow backs up and starts to accumulate in the liver. So just remember that it has a unique circulatory system, blood supply system, and take a look at that figure 30-2 to remind yourself of that. And then table 30-1 about the functions, some of the 20 most important functions of the liver. Then look at figure 30-4, which overviews some of the metabolic functions: metabolism of protein, metabolism of carbohydrates that the liver has responsibility for as well. It also is responsible for bilirubin formation and its elimination, and then read about the relationship of bilirubin elimination related to jaundice. And I'd like you to overview the varieties of hepatitis. About every year they add another letter. They have hepatitis A, B, C, D, E. As they discover new viruses, hepatitis are viral infections. We'll come out with more alphabet soup related to hepatitis. So take a look at the section on hepatitis. And then moving on to cirrhosis, which is basically, I call it the scarring of the liver, and in many cases, the irreversible damage to the liver. There is an excellent video that I want you to watch. And it's a little on the long side for your ebook because most of your videos are 3 or 4 minutes. This is about 7 minutes, but stick with it. It is just an awesome depiction, not only of the circulation through the liver, but also the stages of cirrhosis. And in some cases, it does reference what some of the causes might be. But there's nothing like an animation for most students who have some degree of visual, if you're a visual learner at all. If you're an auditory learner, listen to the narration of the video. But I think it's excellent. I watch all the videos and I look at all the slideshows that are in your ebook, and this one really made me happy because I think it was understandable and it covers a lot of ground in 7 minutes that will help you understand why, when a patient has liver disease, that can be so serious and in some cases deadly. So moving on, when we talk about liver disease, is we have some liver diseases that we consider drug-induced. Sometimes we expose the patients to drugs in the hospital that could cause problems with their liver. But most of the time, the number one drug culprit for drug-induced liver failure is acetaminophen, Tylenol, over the counter. And in many cases, this is non-intentional, but it is simply one of the dangers of over-the-counter medications that patients use indiscriminately because they are over-the-counter. They fail to report to their practitioner that they're even taking them. Your 24-hour maximum for acetaminophen is 3 grams or 3,000 milligrams. So the biggest problem lies where people are taking pain medications, which are a combination of, say, oxycodone and acetaminophen. This would be Percocet. So Vicodin is hydrocodone, and a combination of these and Tylenol. And then they will, in between, say they can take 1 or 2 of these pain pills every 6 hours. In between, maybe at hour 4 or 5, they may be supplementing with an NSAID, a nonsteroidal anti-inflammatory, which is fine if they're taking Motrin or ibuprofen. But if their choice is acetaminophen, then that counts into that 24-hour quantity that a patient can safely take in 24 hours. So we say 3 grams or 300 milligrams in 24 hours, and every source of acetaminophen needs to be counted in that as well. If you refer to figure 30-11, there is a graphic of a SAD patient. This is a depiction of all the complications of cirrhosis that a patient can have. This is where you can start to appreciate the 400 functions of the liver when you see what a patient looks like who has all the complications of liver failure. Then another complication of liver disease and cirrhosis is called portal hypertension. So I want you to read about portal hypertension and then esophageal varices because they very often go hand in hand. Portal hypertension, remember, portal has to do with liver. Hypertension is going to be high pressure or high blood pressure in the liver. And that occurs when there is so much scarring that, remember that 1.5 to 2 liters per minute cannot make its way through the liver because there's so much scar tissue. So it's like the plumbing system starts to back up, and we have what's called portal hypertension. And then one of the manifestations of that is, one could be varicose veins, and the other is varicose veins of the esophagus. That's really what it's like. If you were to put a scope down the esophagus, you'd see bulging of veins. And that is blood that is having a hard time making its way down to the liver. The problem is when those pop or start to bleed, and then we have a patient with bleeding esophageal varices, which can be another complication that can be fatal. Moving on to cancers of the liver. Here you'll differentiate between primary and metastatic tumors. So because of the unique blood flow of the liver, it is a common site for metastasis. And in many cases, until they do a biopsy, they can't tell whether this tumor in the liver is a primary tumor, like you have liver cancer, or this is your colorectal cancer that has now metastasized to the liver. We have 2 more organs to address in this chapter, and that is the gallbladder. And inflammation of the gallbladder we call cholecystitis. And there's a depiction of figure 30-16, which has the most number of gallstones I've ever seen in my life. And I'm wondering if that came from a real life person or not. But basically, obstruction of the gallbladder is a huge problem, not just for the gallbladder, but also for the liver and also for the pancreas. So you'll see how you think of the gallbladder as insignificant because you can't live without your gallbladder. Once people have their gallbladder removed, it doesn't shorten their life expectancy. But if there are undiagnosed problems with the flow through the gallbladder, the flow of bile, basically, because of obstruction or because of some kind of stricture somewhere along the line, it can cause problems for these other organs. And then lastly, we're going to stop at the pancreas. Of course, you know the pancreas plays a vital role in the production of insulin. So when a patient has problems with the pancreas, you can imagine that they'll have some metabolic issues related to insulin production. Here you'll read about acute and chronic pancreatitis. Here again, we do see a fair amount of alcoholic patients who are repeated admissions for pancreatitis, but we also have little church ladies who only drink tea, who have a problem with their gallbladders for some reason that causes them to present with pancreatitis. So you can't judge a book by its cover, and you cannot judge a patient by their diagnosis either. And lastly, we close with the sad truth about pancreatic cancer. And unfortunately, the survival for pancreatic cancer is dismal, and it has not improved of late. So there are some palliative measures that can be taken to address the discomfort, or to, in some cases, the idea of the palliative intervention is to prolong life. My recommendation from working on a surgical oncology floor is that if you have a loved one with pancreatic cancer and someone is suggesting surgery, that you get a second opinion. Because I've seen too many patients that elect for that surgery and then they spend their last 30 days in the hospital following that surgery, where, I don't know, sometimes I think they might have been happier going to Disneyland or something with their family. These are heavy topics that we talk about in nursing courses, not necessarily in pathophysiology courses. There's the sad truth about pancreatic cancer still today, and hopefully it won't always be that way. That is the conclusion of our week on gastrointestinal disorders, and you have no other activities other than to get through these chapters and then quiz yourself. Go to PrepU and pull up quizzes on chapter 28, 29, or 30 and see how you do after you've done the reading. I hope you have a good week. Let me know if you have any questions. Thanks.